It's a pleasure to have you join us on another episode of 360 Health. I am Ogechukwu Okekwe. The federal government, through the Federal Ministry of Health and Social Welfare, has signed a memorandum of understanding with the Colgate Palmolive manufacturers of Colgate to deepen awareness about oral health nationwide. Speaking during the signing ceremony held in Abuja, the Coordinating Minister of Health and Social Welfare, Ali Pate, described the collaboration as a landmark development that will help reduce the prevalence of oral health diseases in the country. The minister, represented at the signing ceremony by the Director of Teaching Hospital, Anuwa Ogbonnaya, noted that the oral diseases affects the poor and socially disadvantaged members of the society. He added that the partnership will encourage more private and public partners to address oral health challenges in the country. The Joint United Nations Programme on AIDS has solicited for an increase in annual investment in HIV response to 29 billion for Nigerians and other low and middle income countries to end HIV epidemic. This call to action comes from the 2024 Global AIDS Report, which highlights the urgent need for increased funding to combat the HIV/AIDS epidemic effectively. The report emphasizes that fully funding the HIV response is crucial for achieving the goal of ending AIDS as a public health threat by 2030. Report shows that approximately 1.9 million people in Nigeria are living with HIV. UNAIDS Executive Director Winnie highlighted that the current funding levels are insufficient to sustain and accelerate progress. We'll go on a short break and we'll be right back. Welcome back. The number of new prostate cancer cases around the world will more than double over the next 2 decades as poorer countries catch up with the aging of richer nations, according to a Lancet report. Findings suggest that the number of new cases annually will rise from 1.4 million in 2020 to 2.9 million by 2040, said the medical journal, based on a study of demographic changes. Researchers behind the study said the rise in cases is linked to the increased life expectancy and changes in the age pyramid around the world. Prostate cancer is the most widespread cancer amongst men. Accounting for about 15% of cases, it mostly emerges after the age of 50 and becomes more frequent as men age. According to researchers, as life expectancy improves in developing countries, the number of prostate cancer also increases. While joining me on the program to discuss further is senior medical official, Touches International Hospital, Dr. Dekan Edet. Thank you for joining me on the program, Doctor. Can you enlighten us on what prostate cancer is and how is it developed, or what leads to it? Because studies have shown that new cases will double in the next 2 decades.
Okay. So I'll start with an introduction of what the prostate gland is. It is a walnut-sized gland between the penis and the urinary bladder. Urinary bladder is where urine is stored. So the prostate gland is at that junction between the penis at the bottom and the bladder at the top. So it wraps around the urethra through which urine passes to the penis. So that structure is found in every male, and the incidence of prostate cancer is uncommon for anybody less than 40 years of age. So it is an abnormality when there are growths in the cells of the prostate gland that is out of typical, when it becomes malignant, when it becomes cancerous rather. So everybody has a prostate. With aging, there could be an enlargement of this prostate gland, and it can give off some symptoms. So many people can go around their life without having any symptom from the prostate, but once there's a manifestation of certain symptoms, it prompts people. For instance, most men that come to the hospital for concerns of the prostate gland have difficulty passing urine, or they pass urine and it's not flowing properly, what we call dribbling or hesitancy. Hesitancy is you want to pee and you have to wait for some time for the urine to come out. If that doesn't happen, some people, they could have frequent nighttime urination, or they urinate and they feel that there's still a content in the bladder, there's still a quantity that has not been voided. So those are the common symptoms that prompt people to come in for checks in our setting. And those things can go on without if the prostate is not enlarged enough to constrict the urethra, which is the pipe for urine, many people do not pick up those signs. So in most cases, prostate cancer can be on for someone's entire late adult life and it's not picked up. So for most people in our climate, that is Nigeria or Africa as a whole, they tend to present a bit late, or these cancers are picked up during screenings. Yes. So development of prostate cancer, going back to the base now, prostate cancer, like many other cancers, is attributed to racial identity. You know, we have the whites, blacks, Asians. That's what we use to classify most people in. So prostate cancer has been found to be more common in people of Black origin. So Black Americans, African Americans, or Africans. So they have almost a two times the incidence of what they have in the whites of prostate cancer. The next risk is a family history. So people that have a father, uncle, or brother that has had prostate cancer are at risk of it. Then the third risk is age. For most people that live long enough, most males that live long enough, they will have an enlargement of the prostate, that's a non-cancerous one, or prostate cancer. So the cause of prostate cancer is not clearly known. There are some risk lifestyle factors that have been attributed to it, like smoking, obesity, but those are found in other common illnesses as well. So the most common risk for most people that are victims of this illness is the family history, the genetic predisposition, that's the racial predisposition, and then age. So how it develops is that over time, maybe lifestyle exposures or the genetic abnormality for people that have a positive family history, it manifests. So it's not as if there is a standard way of saying this lifestyle is going to lead you to have prostate cancer. Most people are counseled based on the racial risk, the age, and then family history. So that's how it is.
So what would you say are the risk factors for developing prostate cancer?
Okay, so going back to that risk, when we eliminate family history, if you're a person of African American or African background, once you are over 40 or 45 years, you're advised to go for screenings. So there are screening tests for prostate cancer. It is something that is bound to happen. So males have testosterone. So the male hormone acts on the prostate gland. It's very sensitive to that hormone. So there's a natural predisposition for the gland to get bigger and for those abnormal cells to occur. So the counseling is more of prevention, going to check, having it checked. So if you feel that there's no family history of cancers or prostate cancer, there is now a standard advice for men that are 40, 45 in particular, and above to go for screenings. So one could incorporate it to his checks annually, so people can have that check done every 2 to 4 years at least. So that's the recommendation. And if that is taken seriously, there are going to be incidents of a detection of a risk. So that screening test is not diagnostic. There's a test called PSA, prostate-specific antigen. That is what is used as the commonest screening test for prostate cancer, or prostate enlargement. Particularly the cancer is what they're looking for. Then the doctor is going to examine you. There's something called rectal examination, where they put a finger to because the prostate is located such that if you want to examine it, it's easier to examine it through the anus, through the rectum. So the doctor can feel for an enlargement and subabnormal textures of the prostate in relation to the rectum. So once that is found in the setting of an elevated or abnormal PSA, it increases the suspicion of cancer. So the argument goes forward that as much as that screening test is the commonest that is being used worldwide, PSA is not a specific test. So it's not once upon a time, we used to believe so much in the PSA. The normal range is 0 to 4 nanograms per mil. But people have found that even for some clients and patients that have these normal values, some of them end up developing cancer. In fact, some have active cancers, but the screening test says the PSA is within normal. So there's now been a move from having it as something suggestive to just being an indicator. So for most people, the doctor is going to try to collaborate your clinical symptoms, the genetic risks, the family history, the racial descent, and not just the PSA. So the PSA is just a weak indicator these days. It could suggest the risk, but it is not absolute. So once there is a suspicion of prostate cancer, for instance, someone has maybe greater than 10 nanograms per mil of PSA from the test, we can escalate to doing an MRI scan, So if it's a suspicion of cancer, an MRI scan is magnetic resonance imaging. So it's a very good modality of scan to pick up structures. So it's going to give us the fine details of abnormal structures within the prostate gland and the pelvis as a whole. So that is what will give us more insight into that looks abnormal. If you look at the films, it will show you the abnormal structures within the prostate. But despite that, that just increases the information you have about the patient that you're suspecting. The definitive diagnosis of prostate cancer in all cases is a biopsy. So the doctor sees what looks like a cancer, he counsels the patient, and they prepare to get a specimen. I'll discuss the procedure later on. To get a specimen from that prostate gland that looks abnormal, different portions of the prostate gland, because it has different segments, to take samples from different parts of it and send for histology. Histology is where a doctor, a pathologist looks at it, comparing to the normal and abnormal cells, and categorizes what the patient has based on those formats. Does it fall under the normal one? Does it fall under the abnormal cells? And which type of abnormal cells? So that is when you can say this person has prostate cancer.
What are the symptoms? What are the common symptoms of prostate cancer, and how can it be diagnosed?
So we'll still start with the statement that most people do not have any symptom at all. When people go through their life, there are many men that in their 40s, 50s, 70s, prostate enlargement or prostate cancer is found during autopsies. Yes. So symptoms manifest for most people when there is gross enlargement of the prostate gland. So as I said, I will still demonstrate. The prostate gland wraps around the urethra. Urethra is a pipe that takes urine from the bladder out. So it's when this structure is squeezing so much on the urethra, that's when the men start to have these symptoms. So if a man has prostate abnormalities, prostate cancer growing in a segment that is not compressing on that urethra, he may not have symptoms. So that's why we say advocate for screening tests, not to wait for symptoms. Good. So if those symptoms happen, it can hardly be like it can save some people's lives because it's a warning sign, but not all people that get to have that. And often for some people, when it gets to manifest that way, it has gone far because it has enlarged possibly. So when there's that enlargement of the prostate gland, it's going to make freedom of the ease of urination to be difficult. So the person will have as much as painful urination or ejaculation. So people are going to notice some blood in their urine or semen. Some people have to wait for the process to relax for urine to come out. That's hesitancy, because you have to hesitate for the urine to come out in bits. And because you have to wait for it to come out in bits, you could have symptoms of incomplete emptying. You feel like there's still some urine left. You go to pee. After a minute, you feel like you're pressed again because it is now opening up for more urine to come out. So that's how it happens. So the frequency, the hesitancy, the dysuria, that's painful urination, those are common signs. But as you heard me mention those things, they're not exclusive to prostate cancer. They are not. Prostate enlargement that is not cancerous can cause that. A urinary tract infection can also cause hesitancy for some people, can cause dysuria, that's painful urination, can cause frequent urination. So the general advice is that if you fall between a certain age group, 45 and above, and you have these symptoms, as much as it looks like, okay, just be UTI, we're advising go and have it checked. Yes, so they're not exclusive. In fact, most people don't call them prostate cancer symptoms. They call it symptoms of lower urinary tracts, just lower urinary tract symptoms. So it's advised that every man of that age category should have the screening when you have any of these symptoms.
So is prostate cancer something that can be managed?
Okay, so with the advent of screening tests, cases are picked up earlier in most developed countries. Okay, so prostate cancer, when confirmed as cancer, it is not a bombshell in most developed countries because they are picked up early. And prostate cancer has two main categories. There is a non-aggressive type and there's an aggressive type of prostate cancer. So there is hardly different stages of treatment. There are people that fall under what they call watchful waiting. Like there's a diagnosis of cancer of the prostate. The histologist says that it's a non-aggressive type, and the doctor, with a constant informed, discussion with the patients, they are just monitoring it. There's also what is called surveillance. They check at intervals to see the PSA trend. So the same PSA that I said is not very reliable, they can now measure it as a trend to see if it changes. If it now rapidly increases, it could create to raise a suspicion that this is becoming more malignant or aggressive. Exactly. So for some people, there is nothing done by doctors. They are monitored and observed. They monitor these vital signs, the investigation, and also they could do some scans to check the size and the trend. There's also a category where if it is confined to the prostate gland, they can do a surgery to take out just the prostate gland. Okay, but as you said, ways of managing it before treatment, the treatment doesn't always have to be surgical. So the treatment should just be that you've reassured the patient and you've discussed what you want to do. So once the diagnosis is made now, that category of monitoring, that is still you offering the care to that patient. But it's not so common in our country because of the time that is discovered. So that surveillance and watchful waiting applies mostly for non-invasive and non-aggressive prostate cancer when found early. But once it's found to be a cancer that has maybe intermediate aggression, or the aggressive type, often, in fact, most times the treatment is surgical.
So let's look at blue balls. How does blue ball and prostate cancer differ? And does blue ball lead to prostate cancer?
They're not related in any way. So blue balls is a very temporary thing, and it's a term used, a slang used to describe a state of engorgement of the male reproductive structure after an arousal or after a period of absence of sex, for instance. But it is classically used when a man has had arousal without an outlet for ejaculation. When a man doesn't ejaculate for a period of time, a healthy man, there are wet dreams. That's nocturnal emission of semen. So nature has its way of getting rid of any excess of semen, in the storage. So since spermatozoa and semen are produced, I'm talking about prostate gland, semen, that's the bulk of the liquid parts of the ejaculate is produced by the prostate gland. The testes just produce sperms. Sperms are the things that move around to fertilize the ovum and cause pregnancy. So the prostate gland is important as where that fluid is produced, the fluid that carries the sperm cells for reproduction. Good. So blue balls do not cause prostate cancer, though research has found that men that ejaculate more often have lower risk of prostate cancer. Okay, so it doesn't mean that men that are abstinent are necessarily going to develop prostate cancer. So I know the topic arises most times in controversy when men are trying to get more frequent sex from their partners or whatever, but blue balls is not related to prostate cancer. No. In fact, by definition, blue balls is a very temporary thing.
Can you explain the stages of prostate cancer with the different stages you mentioned? What are the available treatment options?
Okay, so the stages are going to be very technical and to not benefit the average person. So the main advice that will be communicated to most people is prostate cancer is best found when it's early, when it's confined to the structure, that's maybe the covering of the prostate gland or within the gland itself. If it gets out of the prostate to the surrounding structures like the rectum, that's the rectum is the lower part of the intestine that now leads to the anus and exit of feces. Or if it moves to the spine, that's the backbone, the vertebral bone at the back, that's already indication of spread of the cancer. So for the average person, once we communicate that we are to endeavor to have screenings to catch it early, what we want to catch is to detect the cancer when it is still within the structure of the prostate gland, such that the doctor wants to take it out surgically or want to give any form of treatment, we have it confined to a particular place. So that's the best bet of a good survival rate and cure.
So what would you say are the potential side effects of prostate cancer and how can those side effects be managed?
Okay, so every medication has side effects. And before any treatment is commenced in the present day, of patient advocacy and informed management of cases, the patient is going to be counseled. He's going to be informed of the pros and cons. When you have the concept of the scope of the disease, possibly depending on when it was discovered, the patient is offered the options of treatment. As I said, the best scenario is always early detection. If found early, and say it is the non-aggressive form of prostate cancer, the urologist or oncologist could advise on surveillance. So no treatment, no direct treatment. We're going to be monitoring you. We can do some scans. We could do PSA to monitor the trend of symptoms for you. So the patient is informed, and if he agrees to that, that can be the modality of care. So what that does is that you avoid the risk of any medication or radiotherapy. Radiotherapy kills cells. It aims to kill just the abnormal cells of cancer. But because of its effects, it will burn off even the structuring, surrounding structures. So also the chemotherapy and the hormonal therapy used in prostate cancer treatment have its side effects. For instance, as I said earlier in this presentation, the prostate cancer response and the prostate gland itself responds a lot to the male hormone testosterone. So some forms of treatment will involve administering things to stop the production of the male hormone. When that is done, you are removing, it could come off as a withdrawal or a decrease in some male characteristics. For instance, there could be erectile dysfunction, as the man may not have erections as well or as regularly. There could also be gynecomastia, enlargement of the breast tissue in a man. There could be hair loss. There could be, a reduction in sex drive. So that is part of the side effects of those medications. If you go to radiotherapy, it could cause some damage around the structures. As I said, it could be urinary symptoms. The person could end up having more frequent urination. There could be some bowel movement, as frequency of going to toilet could be affected if the effects of the radiotherapy affects the rectum, and for the extreme other forms of care, including surgery, when you are operating the man, you could cut inadvertently anyway. You can cut some surrounding structures during the surgical procedure. So those are things that the proponents of early detection and surveillance offer their patients that, okay, when we are surveying you, we're trying to delay the need for these other forms of care. But in the bigger picture, despite the side effects, as I told you about, when the patient is made to understand the risk of progression of the cancer as against the side effects, especially if the side effects have their ways of ameliorating them, if there are ways of giving it a softer landing, patients will often choose to survive. They will often choose staying alive over the inconveniences of side effects. So it depends on how early it's detected. You can have a discussion of the side effect profile of the different treatments, and then the patient is still made to understand what you hope to achieve. So most times when the risk-benefit ratio is discussed, many people opt to still go for treatment.
Dr. Dekan Edet, thank you for lending your thoughts on the program. And that's all we can take on this episode of the program. Thank you for watching. Bye for now.